Welcome to the Ross University School of Medicine's Procedural Skills Introduction to X-Ray Chest Pathology Lecture Presentation. I am Dr. Brenton Otey, and I'll be guiding you through this lecture. Let's take a look at our goals. Our goals are to help the students understand the orientation of a standard X-ray, to familiarize students with the terminology associated with taking and interpreting a basic X-ray, and to briefly introduce students to various high-yield chest pathologies, how they alter the physiologic normal adult chest, and what to expect upon imaging with an X-ray. Let's get started. There are multiple types of chest X-ray films, and let's discuss them. We have the antero-posterior, also known as the AP. This is taken from the front, with penetration initially entering the chest first, headed towards the back. There's posterior-anterior, known as the PA. This is taken from the back, with penetration initially entering the back first and headed towards the chest. And then there's the lateral X-ray film, taken from the side, with the standard form being taken from the left side, the patient's left side. Important terminology: density versus lucency. Density refers to brightness. When X-rays are absorbed or blocked by something in the lungs, it appears as an area of brightness on the X-ray. Versus lucency is darkness. When X-rays pass through the less dense areas, for example, air-filled lungs, it appears as an area of darkness on the X-ray. How are you able to determine that an X-ray is adequate and ready for interpretation? We use the right mnemonic: rotation, inspiration, position, and exposure meaning penetration of the X-rays. Rotation refers to making sure that the clavicles are symmetrical and of equal length. Also, the distances between the thoracic spinal processes and clavicular heads should appear to be equal as well. Inspiration: you should be able to count at least 8 posterior ribs if the patient took an adequate breath. Position refers to, is this AP, PA, or lateral X-ray film? And lastly, exposure meaning being able to see the heart, blood vessels, and intervertebral spaces. If the chest X-ray is adequate, you can see the T4 spinous process, which will not be visualized if the image is underexposed. An easy way to remember the interpretation of X-rays is to remember your ABCs. Always check the patient's name and date of film first, but using the ABCDF mnemonic, we look at airway, the bones, cardiac meaning the heart, the diaphragm, extrathoracic tissues, and the fields and fissures. And we'll break those down momentarily. Here's an example of what we mean by airway. The upper airway components, the trachea, carina, and the left and right mainstem bronchus, should all be visualized on an AP film. The red arrows here indicate the trachea. Notice how it is midline. The green arrow represents the carina, while the pink arrows are showing the left and right mainstem bronchus. For the bones, you should be able to number the ribs, and each of the numbers on the X-ray film are the ribs. Remember, you should be able to count at least 8 to 10. Increased rib count could be indicative of hyperinflation, for example, in a patient with COPD. Decreased rib count could be indicative of inadequate inspiration. The red arrow pointing to the structure outlined in their dashed line, which is also red, is the clavicle. Note how there is no clavicular rotation because it is midline. The yellow arrows pointing to the structure with the yellow dashed line is the medial border of the scapula. The green arrows and the green dashed lines are representing the third rib, and the pink dashed line is the vertebrae. Cardiac silhouette and heart borders should be easily identified. The heart base should not be more than half the width of the diaphragm or the chest cavity. The mediastinum should be 6 centimeters max. Any longer would indicate mediastinal widening. The blue arrow and the circle represent the aortopulmonary window. This should be concave. If not, it could be indicative of mediastinal lymphadenopathy and potential aortopulmonary artery aneurysm. The yellow arrow and dashed line represent the aortic arch, while the pink arrow and dashed line represent the heart borders. The yellow arrow is pointing to the diaphragm. There should be that distinctive curve on both ends. If blunted, it could be indicative of hyperinflation. Lack of a sharp contrast between the costophrenic angles and the lung parenchyma can be indicative of fluid accumulation and consolidation, for example, in a patient with pneumonia. The red arrow is showing a gastric air bubble, while the pink dashed lines are representing the costophrenic angles. When we say extrathoracic tissues, we're referring to the lung parenchyma. There should be equal radiolucency when comparing the left to the right and throughout all the zones. Also look for subcutaneous air, foreign bodies, or abnormal densities. When we speak of the fields and fissures, we're talking about the minor and major fissures. The green dashed line represents the minor fissure of the lung, while the red dashed line represent the major fissures. We're also checking for infiltrates. Are they alveolar versus interstitial? Do we see any curly B lines? What about air bronchograms? Any masses that can be located, consolidation, fluid collections, etc. Using the right mnemonic, determine if this chest X-ray is adequate. You can pause the video and take a few seconds if necessary. If after going through your right mnemonic, you determine that this was a physiologic normal chest X-ray, you are correct. Pat yourself on the back. Now that we have a good understanding of what physiologic normal looks like, we can move into the pathology. Here, we have an example of an anterior mediastinal mass. Key pathologies associated with anterior mediastinal masses include the 4 T's: thymoma, teratoma, thyroid, and terrible lymphoma. This chest X-ray represents acute respiratory distress syndrome. A key feature that you'll find on a chest X-ray of a patient with acute respiratory distress syndrome are air bronchograms. This is what happens when the air-filled bronchi are made visible by the opacification of surrounding alveoli. This is almost always caused by a pathologic airspace alveolar process in which something other than air fills the alveoli. Here's a chest X-ray exhibiting a patient with sarcoidosis. The arrows are specifically denoting the hilar lymphadenopathy. Here is another example of hilar lymphadenopathy, just to give you a better idea of what you're looking at and what it would look like on a chest X-ray. Here is an example of congested heart failure. The borders of the heart silhouette cannot be visualized because of the increased densities, the white fluffiness that you see. See how the size of the heart is larger than half the width of the chest cavity in the diaphragm? Not good. Here is an example of what it looks like in a patient with perforation or free air under the diaphragm. Note the air bubble at the patient's right costophrenic angle. Here is an example of tuberculosis in a patient, and specifically the formation of a Gone complex. A Gone complex is the granuloma formation typically in the middle or lower zones of the lung in combination with the transient hilar and/or parenchyma lymphadenopathy and some overlaying pleural reaction. Can you see the consolidation in the right lower lobe? This is a really good example of a lobar pneumonia. In this patient, we have tension pneumothorax being exhibited. Note the tracheal deviation away from the side of the lesion. In this instance, it deviates to the left in this right-sided pneumothorax. The red arrows and the red lines are trying to highlight the tracheal deviation, while the yellow dotted lines are showing the collapsed lung. Here is an example of a thoracic aortic aneurysm. Not particularly high yield, but just wanted to add this for more exposure. The yellow dotted lines are representing the aneurysm. Notice how it is making the trachea deviate to the right? This can also be a cause of a widened mediastinum. And lastly, we have an example of a patient with a right-sided lung abscess.